This lecture is for the 5th grade dental students. The title of this lecture is a Class 1 Malocclusion given by Dr.Nadia, a specialist and a lecturer orthodontist. The main objectives of this lecture is to define what is the meaning of the Class 1 Malocclusion and to know the main etiological factors for the Class 1 Malocclusion, to know the clinical features of the Class 1 Malocclusion, and then we are going to discuss the most commonly problems associated with the Class 1 malocclusion, like the crowding, the spacing, or the maxillary protrusion, and we are going to talk about the management of the Class 1 malocclusion problems, each in detail. At the beginning, let us have a review about the Angles classification of malocclusion. Dr. Angles classified the malocclusion based on the anterior-posterior relationship of the first permanent molars. So we have three classes: the Angles class 1 malocclusion, in which the mesial-buccal cusp of the upper first permanent molar will occlude with the buccal groove of the lower first permanent molar. In class 2, the buccal groove of the lower 6 will be distal to the mesial-buccal cusp of the upper 6, while in class 3, the buccal groove of the lower first permanent molar will be mesial or anterior to the mesial-buccal cusp of the upper 6. So this is the general classification, angle classification of malocclusion. What we mean by the class 1 malocclusion is those cases in which the malalignment of teeth is present, but we have a class 1 molar relationship. It is a very common type of malocclusion and observed in most of the population groups. And it could present with a variety of tooth malpositions, such as crowding, spacing, rotation. You can see here, it can present with a crowding, with a spacing, with a cross bite, with a rotation, open bite, with deep bite, or with anterior cross bite, or with bimaxillary protrusion. We can notice that in all of these cases we have a class 1 malocclusion, but we have individual teeth malpositioning. Now for the etiology of the class 1 malocclusion, it usually can be summarized by mentioning these three important elements for any malocclusion, including the skeletal factor, the soft tissue factor, and the dental factor. And there is a major interplay between them. For the first factor, which is the skeletal factor, is usually favorable, and class 1 we have a skeletal class 1 jaw relationship, as we may see here. This is the maxillary basal bone, this is the mandibular basal bone, in between we have the dentoalveolar structure. The relationship between the maxillary basal bone and the dentoalveolar structure and the mandibular basal bone is class 1, as we may see here, because the patient has a straight profile. But the class 1 malocclusion can happen when we have a mild class 2 jaw relationship or a mild class 3 jaw relationship. As we may see here, the maxilla is slightly protruded and the mandible is slightly retruded, but the dentoalveolar relationship is still a class 1. The opposite is here. The maxilla is slightly retruded and the mandible is slightly protruded, but the dentoalveolar relationship is still a class 1. And this can be explained by what is called the dentoalveolar compensation, which means the teeth are going to move in such a way to hide the disproportionality between the jaw relationship. So in the cases of mild class 2, we may expect the upper teeth to slightly protrude and the lower teeth to slightly protrude. So at the end, we will have a normal occlusion. And the opposite will happen in cases of mild class 3 discrepancies. As we may see here in this patient, she has got a class 1 molar relationship and a class 1 jaw relationship, as we may notice from her profile, which is straight. But she has got a class 1 molar relationship, but a mild class 2 jaw relationship. Of course, the diagnosis will be made by using the cephalometric analysis that we have taken in the previous lecture, by making a model analysis, by the clinical examination, and so forth. The soft tissue factor is usually favorable and it is not an etiological factor, but the main exception for this when we have a bimaxillary proclination, which means we have a proclination of the maxilla and the mandible. This can be racial in origin, but sometimes it may happen because we have lack of lip tonicity, which means we have weak lips to retain the teeth in their position. so they are going to be pushed by the tongue pressure into more forward position. The factor is the main etiological factor for the class 1 malocclusion, and the main cause is the teeth size arch size discrepancy. Like if we have an excess teeth material, the patient is expected to have a crowding. Or if the tooth material is less than the arch size, we will have a spacing. Of course, we have other important dental factors like early loss of deciduous teeth or prolonged retention of deciduous teeth. So when the permanent teeth will erupt, it will be deflected from its position because two objects cannot occupy the same space. Or if we have an abnormality in the number of teeth, like presence of supernumerary teeth, just like we can see here, this is a mesodence. Or if we have abnormality in the form of the teeth, like if we have a gemination, just like we can see here, we have gemination of the central incisors. Here we have gemination of the lateral incisors, and the result is the lack of space for the teeth to be aligned normally. Or sometimes if we have a prolonged retention, just like we said before, of the deciduous teeth, the permanent teeth will either deflected from their position or failure. We will have a failure of eruption, just like we can see here in this picture. Now for the clinical features, extraorally, usually we have a harmonious profile because the jaw relationship is a class 1. So the profile will be straight or slightly convex, except in the cases of bimaxillary proclination. When we have a proclination of both the maxilla and the mandible, the profile may be convex. Also, the relationship for the lips, they may be competent or incompetent depending on the position of jaws and teeth. As we have said before, if we have a bimaxillary protrusion or proclination, we may have lip incompetency, but in general, we should have a competent upper and lower lips. Intraorally, the molar relationship is angle class 1, as we have said before, and we may have either individual teeth malocclusion with a varying degree of severity, or we may have a malocclusion presented in the vertical planes, like we have open bite or deep bite, or transverse planes, which means we may have cross bite, but still we have a class 1 molar relationship. Management of class 1 malocclusion is always aiming at correcting the malocclusion that is present, whether it is vertical, like deep bite or open bite, or transverse, like a cross bite, while maintaining the existing class 1 molar relationship, because it is considered to be the normal molar relationship. So we don't want to change this relationship. It is important. The problems commonly associated with the class 1 malocclusion are the crowding, spacing, or vertical discrepancies like deep bite, open bite, cross bite, or localized teeth problem like rotation and impaction. In this lecture, we are going to discuss the crowding and the spacing, and we are going to leave the other types of problems because it will be discussed separately and in details in the other lectures. Crowding is the most common complaint for which patient seeks orthodontic treatment, especially if it was present anteriorly, as it compromises the facial aesthetic of the patient. We have different types of crowding. It may be present anterior or posterior, in one or both dental arches. We may have mild crowding if the lack of space was less than 4 mm, or as we may see here in this picture, we may have moderate crowding if the lack of space or the deficiency of space was between 5 and 8 mm, just like we can see here, and we have severe crowding if the lack of space was more than 8 mm. The etiological factors for crowdings are so many, but the most important cause and the most common cause is the presence of tooth size arch length discrepancies, sometimes we call it as a primary crowding. The size of the teeth and the size of the arch is genetically determined, and normally there should be a harmony between them, but sometimes we don't, like in cases when we have teeth material excess, so the teeth will not find enough space to fit normally within the dental arch, and the result is a crowding. Nowadays, people are having the crowding much more than they used before, and there are many explanations for this phenomenon. The first one is our change in the dietary habit by depending on the processed food, on the food that needs less chewing from us. In the past, people were depending more on the fiber diets that use a lot of large masticatory forces that cause a stimulation for the growth of the jaws. But nowadays, people are use less masticatory force, so we will have a decrease in the length of the dental arch. The second explanation will be the increase in the amount of the dental caries. So the width of the tooth will be decreased, and we will have an etc. space for the teeth to medially migrate towards that space, and the result is the decrease in the overall arch length. The third cause is the increased outbreeding between people from different racial backgrounds. Like we can see here from this picture, this is a European woman married to an African man. Their child is expected to have a malocclusion, a crowding, if he inherits the size of the dental arch mother and the size of his father's teeth. So the result is the crowding. The opposite is true. If he took his father dental arch size and his mother teeth size, he will have a spacing. The second cause of the environmental premature loss of deciduous teeth. So it is an acquired anomaly here. So it is called a secondary crowding that is caused by the medial drift of the posterior teeth after premature loss of the deciduous teeth in the lateral segments, as we may see here in this picture. There is an early extraction of the second permanent primary molar, so the sixes will be medially drifted, and the result is the lack of space for the five to erupt normally. So it will either be impacted or deflected path of eruption. We have another path of eruption, just like especially in the canine cases, is the prolonged retention of the deciduous teeth, as we may see here in this picture. We have a prolonged retention of deciduous teeth, so that when the permanent will erupt, it will not find enough space to erupt normally, so it will be deflected from its normal position. Also, we have another causes like the microdontia of the teeth that are larger than they are supposed to be, or gemination, malformation of teeth, gemination, so the incisors will be larger, or if we have a supernumerary teeth or a delayed eruption. The late lower incisor crowding or the tertiary crowding is a normal aging phenomenon that occurs during the mid to late teens, which means that the patient will have an increase of any pre-existing lower labial crowding or the emergence of crowding in arches that were well aligned or even spaced in the early teens. And the causes are so many. The etiology of late lower incisor crowding is multifactorial. The first cause is the forward differential growth of the mandible when the maxillary growth has slowed, because as we may know, the growth of the mandible takes longer time than the growth of the maxilla. It will continue to grow while the growth of the maxilla will be significantly decreased. So we will have a differential forward growth of the mandible together with the soft tissue pressure will result in the reduction of the lower arch perimeter, and the result will be a lower labial segment crowding or crowding in the lower incisor region. This is the second theory, or the second cause, is the medial migration of the posterior teeth owing to forces from the interseptal fibers or from the anterior, or this medial migration may be from the anterior component of the forces of occlusion. The third molar may also participate in the developing of the late lower incisor crowding, either actively or passively. How is that? The presence of erupting third molar will push the dentition anteriorly, and so the third molar here will play an active role in developing the late lower incisor crowding. But this theory is very weak, because they found there is a weak association between an erupting third molar and the development of the late lower incisor crowding. Furthermore, this crowding can still happen in patients with congenital missing or congenitally absent third molar. Therefore, the prophylactic removal of the lower third molar to prevent the lower labial segment crowding cannot be justified anymore. What about its role as a passive to develop this phenomenon? While the presence of third molar will prevent the forces or the pressure developed anteriorly, whether it was due to the mandibular growth or the soft tissue pressure, from being distributed distally around the arch. So the third molar here will play a passive role. The final cause for this phenomena is the reduction in the lower intercanine width. In most individuals, intercanine width increases up to 12 to 13 years of age, but this will be followed by a very gradual decrease throughout adult life. The rate of decrease is most noticeable during the mid to late teens, which is the age by which this phenomenon will appear. The management of crowding will depend on creation of a space to solve the problem of space deficiency by using either a fixed or removable appliance, by sometimes using an extraction, and all this will depend on a number of factors. But the key to relieve the crowding is by gaining space. There are many methods for creating the space. The main aim here is to balance the amount of space required with the amount of space available. We may use any of the following depending on the severity of crowding. We may use a proximal stripping to remove part of the enamel using a stripping bear or a strippers or a stripping disc, or we may use distalizers for the molar, a pushing coil spring, or by using a pushing coil spring or by using a screw, So we can use the Z-spring to procline the teeth anteriorly, so we will increase the circumference of the arch, or we can use an expander to expand the arch, a jack screw expander, or in some cases we may extract teeth to create the space, but we have to make sure that all the teeth are present before taking the decision of extraction. Now for the spacing is the other problem of a class 1 malocclusion. It may be seen in one or both dental arches. It may be localized or generalized. It may be unilateral or bilateral. It may present between the two permanent maxillary centrals in the midline, and in this case we may call it the midline diastema. Physiological factors for the development of spacing. The first one is the teeth size arch length discrepancy, which means we have a small teeth and a large jaw, so we will have an excess space between the teeth. The other second cause is the presence of oral habits, just like the thumb sucking or the tongue thrusting, so the teeth will be pushed anteriorly. Or we have an abnormality in the tooth form, just like the peak-shaped lateral incisors, so we will have a space between them and the adjacent teeth. The other cause is the presence of abnormally large tongue that is going to push the teeth anteriorly, or abnormality in the teeth size, small teeth, microdontia, as we may see here. This is a peak-shaped lateral incisor, but the other side is also small, and the result is the presence of spacing. Or if we have anomalies in the number of teeth, hypodontia or oligodontia, we will have spacing between the remaining teeth. Orthodontic management of spacing depends on the amount of space and also on the position of the space, whether it is located anteriorly, posteriorly, whether it is localized or generalized. In general, the generalized spacing is frequently difficult because there is a tendency for the spaces to reopen, unless we may consider using a permanent retainer. In the milder cases, it may be wise to encourage the patient to accept the spacing. And if the teeth are narrower than the average, we may use an acid-etch composite, aesthetic composite additions, or porcelain veneers to close the space, to widen them a little and improve the aesthetic of the patient. In severe cases of hypodontia, we should have a combined orthodontic and restorative approach to close the space by using a prosthetic, by using an implant. Any one of them may be required, as we may see here. This is a congenitally missing lateral incisor. There is a spacing between the teeth, so the first one is to consolidate the space between the two centrals, and so we will have enough space for the lateral. Then we use an artificial tooth, whether it was implant or whether a bridge or whatever, to close this space. Now for the median diastema, which means that there is a space between the two central incisors, and it is more common in the upper arch than the lower arch. There are many causes for the presence of this space. The first one is normal, physiological. In the early mixed dentition, the frenal attachment will be high up to the incisive papillae, but later on, with the further growth of the jaw and with the eruption of the teeth, this frenal attachment will be migrate in an upward direction to be inserted in the labial mucosa. And the other cause is the presence of microdontia, small teeth, or absence of teeth, hypodontia, or the presence of supernumerary teeth, especially the presence of mesodents. The median diastema, which means the presence of a space between the two centrals, maybe in the upper or in the lower, but it is more common in the upper arch. And there are many causes for the presence of such a space. The first one is the normal physiological, because in the early mixed dentition, normally the frenal attachment will be attached to the incisive papilla, but later on with the growth of the jaws and also with the growth of the alveolar bone and with the further eruption of teeth, this frenal attachment will be migrate in an upward direction. So in the early mixed dentition, the presence of diastema is considered to be normal. The other cause is the presence of microdontia, small teeth, or hypodontia or oligodontia, as we said before, or the presence of supernumerary tooth, which is the most common cause of median diastema, or sometimes a frenal attachment. As we said before, normally during the early mixed dentition, the frenal attachment is attached to the incisor papilla. If it doesn't migrate, it will prevent the approximation of the two centrals together, and so the space between them will persist. So it is abnormal if it presents in the late mixed dentition or in the permanent dentition. Also, the proclination of teeth will also cause a median diastema. Diagnosis will depend on two important examinations, the clinical examination or the blanch test. By pulling the upper lip in an upward direction, the frenum will be pulled, and if there is a blanching palatally at the incisive area, it means that there are fibers inserted in here. The other examination is the radiographical examination. We should make a periapical radiograph, and if we see a radiolucency between the two centrals, it means that there is fibers inserted in here. For the management of median diastema, we should wait until the eruption of permanent canine because it usually normally decreases after the permanent canine eruption. And we should not intervene unless it is necessary, like if the diastema is greater than 3 mm or if there is a lack of space for the lateral incisor to erupt. After the eruption of the permanent canines, the space closure is usually straightforward. We usually use the fixed appliance to consolidate the space and to achieve the uprightening of the incisors. But we may consider using a prolonged retention or permanent retainer because the diastema have a great tendency to reopen, especially if there is a family history. And if it is thought that the frenum is a contributory factor, then we may consider using a frenectomy, and it is best carried out following the space closure. This is the frenectomy. We close the space first, then we consider using the frenectomy because the scar tissue contraction will help us in space closure. The third problem of the class 1 malocclusion is the bimaxillary proclination. This term is used to describe occlusions where both the upper and the lower incisors are proclined, but the molar relationship are class 1 relationship. The management of the bimaxillary proclination is usually difficult because both upper and the lower incisors need to be retroclined to reduce the overjet. The retroclination of the lower labial segment or the lower incisors will decrease the tongue space, will place pressure on the tongue place, and so there is a high possibility of relapse following the removal of appliance. And the management of the bimaxillary protrusion is greatly depends on the lip tonicity, on the relationship between the lips. If the lips are incompetent but have a good muscle tonicity to retain the result and are likely to achieve a lip-to-lip seal after treatment, after the orthodontic treatment and after the retraction of the incisors, the chance of a stable result are increased. But if the bimaxillary proclination is associated with the competent lips or with grossly incompetent lips that are unlikely to retain the corrected incisor position, it may be wiser not to proceed with the orthodontic treatment because the relapse is very high. And if we decided to make a treatment, the permanent retention is very advisable in these cases to have a stable results. Thank you, and this is the end of the lecture. If you have any question, please do not hesitate to contact me. Best regards.